Welcome to the Deep Dive. We aim to give you the crucial medical knowledge you need, fast and clear. Today, we're diving into hepatitis D, also known as delta hepatitis.
Yeah, and it's a really interesting one. Its whole existence hinges on another virus, which is pretty unusual.
Exactly. So we've gone through our revision notes, pulled out the key stuff on Hep D. Our aim today, get you completely clear on what it is, the causes, risks, how it affects the body, how we spot it, manage it, and the likely outlook.
We'll try and make it stick, maybe with some memory aids along the way.
Right then, let's start with the basics. What is hepatitis D?
Okay, so our notes define it as liver inflammation caused by the hepatitis D virus, or HDV. But the absolute key point, like we just hinted, is that HDV infection can only happen in someone who's already got the hepatitis B virus, HBV.
So it's like a compulsory partnership. HDV needs HBV to even get going.
Precisely. It hijacks HBV's machinery to replicate. And this combo often leads to liver inflammation that's, well, potentially more severe than if you just had HBV alone.
Got it. And worth remembering, it's a notifiable disease here in the UK.
Yes, important point. And just for context, there are other hepatitis viruses, A, B, C, E are the main ones causing viral hepatitis.
Yeah.
But liver inflammation isn't always a virus, right? It could be medications, toxins, even autoimmune issues.
True. But for Hep D, the non-negotiable is the hepatitis B surface antigen, HBsAg. If that's not around, HDV simply can't establish itself.
Exactly. No HBsAg, no HDV infection. It's the entry ticket, essentially.
Okay, let's talk etiology. The why.
Right. The cause is the hepatitis D virus itself. It's an RNA virus, but importantly, it's described as defective.
Defective meaning it can't do everything on its own.
Spot on. It lacks the ability to create its own outer shell. It needs to borrow the envelope proteins, the coat, from HBV.
So that explains the absolute dependence. You can only get Hep D if you already have HBV or if you happen to acquire both viruses at the exact same time.
Correct. That simultaneous infection is called co-infection.
Mm-hmm.
Getting HDV when you already have chronic HBV is called superinfection.
And how does it spread? Same as Hep B, I assume.
Pretty much, yes.
No.
Contact with infected blood or bodily fluids. So sharing needles, that kind of percutaneous exposure, and sexual transmission are the main routes.
Our notes mention perinatal transmission mother to baby is rare, though.
Yes, thankfully less common than with HBV itself.
Here's a little memory aid, maybe.
Yeah.
Think of that Greek letter delta. It looks a bit like a triangle needing a base. Imagine that base is the big B for hepatitis B. Delta always needs its B.
Ooh, I like that visual. Delta needing its B base.
Good one.
And that leads us straight into risk factors. The biggest one is obvious, isn't it?
Having hepatitis B current or even past infection.
Absolutely. That's prerequisite number one.
But our notes also flag specific behaviors that increase the risk of getting both viruses.
Yeah, things like injection drug use, especially sharing equipment.
Unprotected sex, particularly with multiple partners.
And any situation involving exposure to contaminated needles or blood products, maybe occupational exposure in healthcare, although that's much rarer now with universal precautions.
And these all tie back directly to those transmission routes we just discussed, blood and bodily fluids.
Exactly. It's all about facilitating that exchange.
Okay, let's dig into the pathophysiology. How does this actually work inside the body, in the liver cells?
So the core mechanism is HBV using HBV's envelope proteins, specifically HBsAg, to package new HDV particles inside the liver cells, the hepatocytes. It's basically hijacking the HBV assembly line.
Right, using HBV's coat to make more of itself. And you mentioned co-infection versus superinfection earlier.
Yes, and the distinction is really important for prognosis. Co-infection is getting both HBV and HDV together. Superinfection is getting HDV after you already have chronic HBV.
And superinfection tends to be worse.
Generally, yes. Our notes highlight that both can cause more severe liver damage than HBV alone, but superinfection often leads to a faster progression towards chronic hepatitis and cirrhosis. It's a more aggressive hit on a liver already dealing with HBV.
Makes sense. It's like adding fuel to an existing fire.
A good analogy. And just stepping back for a second, remember, viral hepatitis is inflammation caused by those liver-loving or hepatotropic viruses, A, B, C, D, E.
Though other viruses can sometimes cause hepatitis too, right? Like CMV or Epstein-Barr.
They can, yes, but they don't primarily target the liver like the main hepatitis viruses do. Adenovirus, herpes simplex too.
And some of these main ones, especially HBV and HCV, can cause issues outside the liver, extrahepatic stuff.
That's right. They can have systemic effects sometimes.
Okay, so if someone comes in with liver inflammation, we can't just assume it's Hep D. What else should be on the list? The differential diagnosis.
Absolutely crucial. First, you consider the other main viral players, hepatitis A, B, C, and E.
Then the non-viral causes we touched on.
Exactly. Autoimmune hepatitis, drug-induced liver injury, DIL, and alcoholic hepatitis are big ones.
And for someone presenting with acute hepatitis, that list gets even broader.
Oh, yes. You think about drugs, toxins, alcohol, certainly. Other infections like glandular fever, infectious mononucleosis, CMV again. Even less common things depending on travel or exposure, history, Q fever, lepto, syphilis, malaria, yellow fever. Anything causing jaundice needs thinking about.
And for chronic liver inflammation.
Chronic hepatitis differentials include ongoing alcohol use, certain drugs, autoimmune hepatitis again, and inherited conditions like hemochromatosis or Wilson's disease.
And this is the key filter for Hep D, you absolutely must have that positive HBsAg result to even consider HDV.
100%. If HBsAg is negative, hepatitis D is off the table.
Okay, let's look at the numbers. Epidemiology. How common is this?
Globally, the estimates are around 15 to 20 million people with HBV are also co-infected with HDV, so significant number worldwide.
And it's more common in certain parts of the world.
Yes, our sources pinpoint areas like the Mediterranean basin, parts of Eastern Europe, the Middle East, across Africa, and parts of South America. In these regions, HDV is a really important cause of severe liver disease and cirrhosis.
What about here in the UK?
It's considered relatively rare in the general UK population.
But potentially more prevalent in the certain groups.
Exactly. You might see higher rates in people originating from those high prevalence regions we just mentioned, or within specific high-risk groups like people who inject drugs, mirroring the HBV patterns.
And just generally, the hepatitis landscape in the UK has changed a bit, hasn't it?
It has, largely thanks to vaccination against Hep A and Hep B. Those have decreased significantly. And there's much more recognition now of hepatitis E as a cause of acute hepatitis in the UK.
Right. Useful context. So clinical features. How might someone with hepatitis D actually present?
Well, often it looks very similar to hepatitis B. The presentation can be really variable, could range from completely asymptomatic, no symptoms at all,
To really severe acute hepatitis.
exactly. When symptoms do show up, they're the typical ones. Fatigue, jaundice, the yellow skin, and eyes, dark urine, maybe some abdominal pain, and enlarged liver you might feel on examination.
And the critical thing is that chronic HDV infection really ramps up the risk of cirrhosis and other liver complications down the line.
Definitely. Just to quickly recap, general acute viral hepatitis symptoms, because they overlap, nausea, vomiting, muscle aches, that profound fatigue, right upper quadrant pain, sometimes altered mental state in severe cases, maybe cold-like symptoms initially, light sensitivity, headache, sometimes diarrhea, pale stools, dark urine. Jaundice is often the most striking sign.
And physically, you might find an enlarged liver or spleen, maybe some swollen glands.
And the worry, as our notes mention, is potential progression to acute liver failure, although that's thankfully not the most common outcome.
And it's worth stressing that chronic infection with B, C, or D can often be silent for years, decades even, while still causing damage.
Absolutely. The damage from HDV seems to be immune-mediated. The body's response causes the liver cell injury. And having both HDD and HBV just significantly increases the risk of severe hepatitis, rapid progression to cirrhosis, and liver cancer compared to HBV alone.
So how do we confirm the diagnosis? What are the key investigations?
Okay, the core tests are serological. First, you need to confirm HBsAg is positive, proving HBV is present.
The prerequisite.
Exactly. Then you test specifically for HDV antibodies, that's anti-HDV.
And can you detect the virus itself?
Yes, using HDV RNA testing, usually via PCR, reverse transcriptase PCR. This directly detects the viral genetic material.
Alongside the specific tests, you do standard liver tests.
Oh, absolutely.
Sure.
Liver function tests, LFTs, are crucial to see how inflamed or damaged the liver is. Imaging like ultrasound, CT, or MRI might be used too, mainly to look for signs of chronic liver disease, cirrhosis, or complications like liver cancer.
And sometimes a liver biopsy.
It might be needed, yes, particularly to stage the degree of fibrosis or inflammation to assess how much scarring there is. It gives a direct look at the liver tissue.
Our notes also mention other tests might be needed depending on the situation.
Yeah, if someone's very unwell, showing signs of liver failure, or if cirrhosis or cancer is suspected, you'd likely do a full blood count, check kidney function, urea, and electrolytes. And importantly, clotting studies like the INR, as liver failure affects blood clotting.
And maybe repeat the hepatitis serology panels just to be thorough.
Definitely. Confirms the HBV status and rules out other coexisting viral hepatitis.
Right, so we've found it. How do we manage hepatitis D, particularly here in the UK?
Well, the main strategy, according to our sources, is actually controlling the underlying hepatitis B infection.
Because there isn't a specific widely available drug just for HDV.
Not really, no. So the approach is to use antiviral medications that target HBV things like nucleoside or nucleotide analogs. By suppressing HBV replication, the hope is to indirectly reduce the impact of HDV, since HDV relies on HBV.
Makes sense. Hit the helper virus.
Exactly. But the most crucial thing, really emphasized in our notes, is prevention through HBV vaccination.
Ah, because if you prevent Hep B,
You automatically prevent Hep D, co-infection, or superinfection. It's the cornerstone of preventing HDV, so HBV vaccination is key.
good point. What about actual treatments for established HDV infection?
Options are a bit limited, but improving. Pegylated interferon alpha is one possibility. It has antiviral and immunomodulatory effects. It can sometimes lead to HDV clearance, but has significant side effects.
And liver transplant.
But that's an option for end-stage liver disease caused by HDV, potentially curative if successful, but obviously a major procedure with its own risks and challenges.
Our notes mention a newer drug, bulevirtide.
Yes, bulevirtide. It's an entry inhibitor stopping HDV and HBV from getting into liver cells. NICE has recommended it for adults with chronic Hep D and compensated liver disease, especially if interferon isn't suitable or hasn't worked. It's a significant step forward.
Okay, good to know there are evolving options. Now, prognosis. What's the long-term outlook like?
It really varies. Factors like how severe the liver disease is when diagnosed, whether cirrhosis is already present, and how the person responds to treatment all play a role. But the unfortunate reality is that chronic hepatitis D significantly increases the risk of progressing to cirrhosis, developing hepatocellular carcinoma, liver cancer, and eventually liver failure compared to HBV alone.
So, early diagnosis and management are really critical for improving those outcomes.
Absolutely. Regular monitoring is essential to catch complications early and adjust management.
Which brings us neatly to complications. What are the main ones we worry about with Hep D?
Our notes list the big ones. Developing chronic hepatitis, if not already present, liver cirrhosis, liver failure, and hepatocellular carcinoma.
And just to reiterate, the risk of these is substantially higher with HDV-HBV co-infection compared to just having chronic HBV.
Yes, significantly higher. That synergistic damage is a real concern.
It really highlights the need for close follow-up, proper medical care, and focusing on those preventive strategies, especially HBV vaccination.
Couldn't agree more. Those are vital.
Okay, let's wrap up this deep dive on hepatitis D, the main takeaway. It's a serious liver condition, but it only affects people who also have hepatitis B, and unfortunately, it often makes the liver disease more severe.
And because of that dependency, the #1 way to prevent hepatitis D is to prevent hepatitis B, primarily through vaccination.
Definitely. Now, if you want to consolidate this and explore more revision resources, do check out passthemsra.com.
And for a great range of free learning materials, including notes and questions, head over to freemsra.com.
Both excellent sites to support your medical learning.
And finally, thinking about Hep D really drives home how interconnected viruses can be. Understanding these kinds of relationships, these dependencies, is absolutely key for tackling them effectively, both in terms of prevention and finding new treatments. It's a complex but fascinating field.